You'll be pleased to know I'm just the warm-up act for someone who is far more impressive than me. But before I introduce them, I'm going to take you to Cambodia, where I was visiting not to try and find the next Lara Croft at the top of the Tomb Raider temples, although that was partially an ambition, but to visit an incredible little institution in Angkor called Angkor Hospital for Children. Angkor Hospital for Children is absolutely remarkable. It is a leading centre of excellence in Cambodia, a country of 20 million people, where they do amazing work in antimicrobial resistance and the study of which new antibiotics and techniques might work. But they also are able to treat 138,000 cases for just $3 million a year, which is pretty good going, run by an amazing lady who is a pediatric neonatal intensive care specialist formerly from the UK. And they also are a leading centre of excellence for cancer. Here are two kids with cancer. On the left-hand side is a child who is being examined for retinoblastoma. Anyone had a kid here? Few people. I can't see anything, it's dark. Does anyone remember when the doctor shone a little light in the back of the eye? Right? I see some nodding shadows. It's like Lord of the Rings. There's some sort of stuff in the darkness. That's to have a look for whether the light is red. It's called the red reflex. And if it isn't red, it shines a bit of white. And if it's white, then it could be this thing that can make you blind called retinoblastoma. And guess what? They don't do it in Cambodia because they haven't got the resources to do it. So there's an epidemic, as well as being a genetic predisposition, there's an epidemic of retinoblastoma, which Claudia, the CEO of this hospital and this place, is doing a great job of eliminating. It's remarkable work. On the right, however, is a child with ALL. The thing that is pretty well cured. In most centres, about 90% cure rate. It's getting up to 95 now in some places. It's a paediatric leukemia, which here we cure all the time. Angkor Hospital for Children, as the leading cancer centre of excellence for kids in a country of 20 million people, treats 30 of these kids a year. It is actually the only paediatric cancer centre in all of Cambodia. And in all of Cambodia, only 30 kids get treated a year. Why? It's not because they don't have access to chemotherapy. It's because the toxicity of dealing with what is actually quite a complex process, not just the drug, but the fact that your immune system gets crushed, means that they can't send kids home. They all die. And the result is that only 1% of kids with ALL in this country survive more than 5 years. It is not just the marvelous drugs that we create, but it's also about having the infrastructure and thinking when we're developing these therapies, what is going to be sustainable and less toxic and easier to give people. And it's something that we don't think about when we're developing stuff for just ourselves in rich countries, because we kind of don't think, well, what about the 4/5 of the planet that actually could benefit from some of the stuff which we're inventing for ourselves? I'm going to take you to the other side of the world now, and you might have recognized this from exactly this time last year. It's the same slide I brought up. Other side of the world, same planet, but actually a different world. Silicon Valley, chap in the middle with a hat, friend of mine, and if you remember the story, he had just sold his gene sequencing company to a very big biopharma company for $350 million. A couple of weeks later, falls unconscious on his cycling machine at home and goes to Stanford University Hospital and is diagnosed with a glioblastoma and is given approximately 12 months to live. Now, being a Silicon Valley entrepreneur, of course, he doesn't accept this as an answer and goodness knows what amount of gene sequencing, whole exome sequencing, mRNA sequencing, multi-epitope vaccines, dendritic cell vaccines, conventional IO, weird IO that you've never heard of but will do in a few years' time. I'm pleased to say that having seen him 3 days ago, he has zero tumor burden. He has nothing on his MRI. He has no circulating tumor DNA in his blood. And baffling everybody, he is essentially cured. Well, we don't know, but at least, very least, in deep remission. Okay? But let's have a think about this and go back to Cambodia for 1 second. All of this stuff is all well and good, but will it ever get its hands into all of us? And we're already seeing this. You know, this is the stuff that might cost about $1 million or $2 million a year to actually test on an individual person. This is not necessarily scalable. What about our cost-constrained healthcare systems that we're all living in, certainly ours here today? A friend of his called me up recently and asked me if I would be able to go and see somebody up the road from me, a family who had also been given some bad news and with the same diagnosis. So I went up the road, up in Highgate, and I met this wonderful family, this lady called Tessa, her daughter Jess, and Tessa's grandchild Otti there, and I met them all in their house, and I guess I was just there to sort of try to communicate with them about the fact that there were options for glioblastoma. You could think that Stefan is an anecdote, but he's amongst a few sort of super survivor outliers who have beaten this stuff as a result of really deeply understanding what's going on and using combinations which include at its very core immunotherapy. I think it took me about 30 seconds to realize what an incredible family this was. Tessa's an amazing person. I know nothing about politics. I kind of foolishly asked whether she was Labour or Tory. Not really sure, but of course she was in Tony Blair's cabinet when she was serving in Parliament, and later on appointed to the House of Lords. An absolutely remarkable woman, but equally remarkable her family and Jess, who pushed and pushed for the same kind of access that is enjoyed by people with limitless money and limitless connections, like people like the person in Silicon Valley, and really pushed the government to try to be savvy and sensible and swift about what treatments were available beyond the standard of care, which gives you only 12.4 months in the UK. And so what Jess and Tessa did after an absolutely remarkable House of Lords debate in January this year, pleading for a change in the way that we do things, they launched the UK Brain Cancer Mission, which is a UK government-led international effort to adopt the first national scale program enabling combinations of therapies to be tried at the same time in a completely different way to the way we test science today. We normally have standard of care, and if you're lucky, you get on an RCT, a randomized controlled trial. But only 2% of people with glioblastoma get on a randomized trial. We talked about the number of eligible people, and we talk about the number of trials that there are. Well, guess what? 3,950 out of the 4,000 people each year with glioblastoma, the toughest disease in all cancer probably, get to go on a trial. And the net result of that, so far after 50 years, there has basically been no change in overall survival. Why? The reason is because glioblastoma is a jolly complex disease. And when you get a jolly complex thing with about 200 things going on, testing one thing at a time and waiting for a result every 5 years results in what? Not a lot. Okay? These complex systems biology problems that we have fortunately in a way been left with, because we fixed a lot of the simple stuff, is what we're left with. And we need smarter ways, more adaptive ways, more combinations that are being adapted in real time in order to test out what's going to work for certain types of people. And so think about, instead of thinking about randomized controlled trials, think about adaptive clinical treatments or collaborative treatments. And that's exactly what Jess and Tessa started, was a charity called ACT, which stands for Adaptive Collaborative Treatments. Adaptive because it will be a national program to attempt to get lots of combinations of things that match the molecular profile of the disease. Collaborative because it will involve interaction between different centers of excellence, not just one oncologist feeling really scared about these 30 things going on. And not just being in a trial that's limited to a certain few people, but this being a kind of alternative standard of care from which we're learning in real time. It turns out, crazily enough, that it is actually far cheaper to test out combinations of things in such a way than it is to do randomized trials. So there's lots and lots of good reasons for doing it. The big question is, are the individual pharma companies going to know what works and what doesn't? Or is it just going to be this combination and the algorithms that help us adapt that to each patient that actually are the cure? So before moving on and introducing Jess to the stage, I just want to say that what Jess and Tessa have done is to help us acknowledge that in all of this innovation that we're pulling together, it shouldn't just be focused for the very, very wealthy countries or the highly accessible, highly networked people. We should be thinking about becoming smart on how to test things that have been designed to be scaled out to everybody. And immunotherapy, funnily enough, has that capability. We need to develop strategies which are suitable not only for the billionaires, not only even for our cost-constrained healthcare systems, but also things that will be able to help people like that kid and their family in Cambodia. And that is exactly what our next speaker is going to talk about. Can I please ask you to give a very warm welcome to Jess Mills.